I'd like to thank Dr. B.R. Das and the organizers for giving me this opportunity to be with you here today. I was with MPAI when it was formed, and it's really such a pleasure to be here and see its growth at age 10. Today, I'll share with you how we utilize next-gen sequencing in thyroid cytopathology in the US, how it helps us stratify risk, and explain the molecular landscape of thyroid carcinogenesis. Let's start with a patient. This 57-year-old noticed an anterior neck mass. The physician felt it was a thyroid nodule, and on ultrasound, it was 9 millimeters. We do perform ROSE, rapid assessment, on site, and you can see it was a cellular sample with abundant colloid and a lot of follicular epithelial cells in a mixed macro and micro follicular pattern. We called it FLUS and requested ThyroSeq, a next-gen sequencing assay for indeterminate and atypical aspirates. The way it works is if ThyroSeq is positive, patient undergoes surgery. So what is ThyroSeq? When it first started in 2007, it used the Sanger platform's 7-gene panel, and the sensitivity was low. Now in 2017, since 2017, it uses a 112-gene panel, and the sensitivity is 93%. It's quite an exhaustive panel with 12,000 mutational hotspots, 120 fusion types, mutations, insertions, deletions, gene fusions, gene expressions, copy number alterations. It does tell you if it's a medullary carcinoma. 0.6% of thyroid FNAs detect parathyroid cells, and it does that. It's also very good for Hürthle cell lesions. In our patient, the ThyroSeq was positive and surgery was performed. This was the nodule 9 millimeters that was removed, and you can see there's a lymph node here and a cystic area, which is also seen on the section. We thought it was benign. It had all these colloid follicles, and this rim calcification, which disrupted the nodule. There were lymphocytes and foreign body giant cells, which indicated that this was post-FNA. There were some clear areas, but we didn't see any papillary nuclear features, and we called it benign. We didn't mention that there was an NTRK3 fusion seen. Then the next thing I know, I received a call from Nikiphora from the University of Pittsburgh, and he said, could I look at that case, because usually that is a papillary carcinoma that can be very bland. And I was happy to be corrected. I said, absolutely. And I sent him the slides. What as a surgical pathologist, I went by histology and not by the molecular report. And the molecular report had said that the probability of cancer is 95%. And there is an ETV NTRK3 fusion. Actually, that was the case that was presented in the lung cancer that was discussed earlier. And it did say that there will be a low-grade cytologic appearance. So I went back to the slides, and there near the calcification was some Samoma bodies and some nuclear inclusions. And you can see the nuclear inclusions here. Very subtle. The capsule was disrupted, but I had attributed it to the prior FNA. So we revised our diagnosis and called it an NTRK3 associated encapsulated papillary thyroid cancer follicular variant. So what is this tumor? It's a recently described entity making up 2% of thyroid tumors and has a deceptively bland morphology. What's the importance of diagnosing it? In an advanced case, you can use a drug such as entrectinib There are other carcinomas that we know, secretory carcinoma of the breast, mammary analog secretory carcinoma, the salivary gland associated with this translocation. And if you see in the tumor that I showed, there were some sort of secretory vacuolated appearance areas. This is a very good article by Nikiforov, where it shows these tumors having a multinodular appearance, ours didn't, a papillary architecture, ours didn't, and these clear areas, again, ours were more subtle. There's also reversed polarity, wherein the nuclei on the luminal surface and not at the base. So why do you do next-gen sequencing in the thyroid? It's because to avoid unnecessary surgery for indeterminate nodules, in 61% of the cases, you can distinguish high risk from low risk. You can tell which patient needs a lobectomy and which needs a thyroidectomy. So how did this all come about? So after the Human Genome Project, there was the Cancer Genome Atlas, which highlighted the genes responsible for genetic alterations in thyroid neoplasia, with BRAF V6OE being the most common point mutation in classic papillary carcinoma. And we just heard that there is a drug for this mutation now. And P53 and TERT mutations actually deliver an adverse prognosis. So where are we in 2023? If there are no mutations, you can observe the patient. Some mutations, just active surveillance is okay. With the RAS family and others, a diagnostic lobectomy. With still others, a total thyroidectomy. And with mutations of P53 or TERT, you may want to do a lymph node dissection. So these mutations in the RAS family and some BRAF actually are specific for neoplasia. That means tumors, but not necessarily malignancy. In these cases, then, a diagnostic lobectomy is what is needed. In still others, RET, ALK, and the NTRK that I showed you, along with BRAF V600E, these are essentially diagnostic of cancer and hence need a thyroidectomy. Still others need lymph node dissection because these, in combination with aforementioned driver alterations, are found with increased frequency in aggressive thyroid cancers, such as poorly differentiated carcinoma and anaplastic carcinomas. Hürthle cell tumors show a different genotype with loss of chromosome 7, duplication of chromosome 7. And when I think of a Hürthle cell, I think of a pink cell. And this cell then has a lot of mitochondrial DNA mutations. Medullary carcinomas show RET mutations and microRNA 375 overexpression. Still other mutations are associated with benign tumors. Again, NTRK3 is amenable to targeted therapy. And in our experience, we also detect P53 germline and DICER1 germline mutations. You can imagine a patient coming for a thyroid nodule FNA and leaves with the report of a germline P53 mutation and Lie-Fraumeni syndrome. This highlights the power and the powerful technique of next-gen sequencing. Thyroid is the only gland where next-gen sequencing is done before the diagnosis of cancer. No other organ do you do next-gen sequencing before the diagnosis. Usually next-gen is done after the diagnosis of cancer, but it's only in the thyroid gland that you do next-gen sequencing even before the diagnosis of cancer, and use the next-gen sequencing to utilize management. Yes surgery, no surgery, what surgery, which kind of surgery, etc. So how is this incorporated in clinical medicine? We know in the US, and I don't know the Indian stats, but in 2022, we'll have 43,800 new cases with 2,230 deaths. And usually thyroid cancer presents at a thyroid nodule. Most of these nodules are benign. Only 5% harbor a malignancy. The American Thyroid Association guidelines state that any nodule greater than 1 centimeter should be FNA'd. our nodule in our patient was 9 millimeter. That's because it had some high-risk features. We do use TIRADs like BIRADs for the assessment clinically of thyroid nodules. These are the Bethesda categories where next-gen sequencing is done, 3, 4, and 5. This avoids surgery in 61% of cases. I know next-gen sequencing is expensive. Our test costs about $3,000. But the insurance companies have determined that if you avoid surgery, it's economical to do the next-gen sequencing in these categories. We used to do next-gen sequencing not upfront, but since 2018, we are doing it upfront. So what we do, the first 2 passes are for adequacy. The third pass, we collect in the thyrosic medium in a small vial. And if it's in these 3 categories of atypia and indeterminate, we send it out for next-gen sequencing. When I analyzed our data, we send about 50 cases per year for next-gen, and half of them have mutations. I completed this analysis for 2021, 22, and you can see the number is constant with about 50 to 60% positive for mutations. So what are the mutations that we see? Most of them are in the RAS family, as reported in the literature. BRAF is associated with papillary carcinomas. Here is our case of NTRK3. We do see TERT and ALK, and also DISO1. Here's our germline mutation for P53 and other P53 mutations. Coming to 2020, 21, and 22, again, the RAS family predominates, followed by BRAF. Here's our DISO1 mutations, NTRK3 mutations, ALK, and TERT. So I'll end with another patient. She's a 26-year-old with a 1.5 centimeter nodule. She had an FNA. She actually was diagnosed with goiter when she was but 15 years old. Goiter is very uncommon in the US. At that time, the ultrasound and thyroid levels were normal. However, she had a strong history of thyroid and ovarian cancer. She was religiously followed by her endocrinologist. You know, we practice defensive medicine in America, and this is a good example of it. In 2016, her nodule was 1.2 centimeters. In 2017, her nodule was 1.4 centimeters. In 2018, it was 1.5 centimeters. At that time, the clinician said, that's it, she gets an FNA. And we got this sample, which was quite cellular, and you can see the microfollicular pattern. There's no inflammatory component. And we again called it plus a follicular lesion of unknown significance. In the new Bethesda that will come out, this category will be replaced with AUS. As required, we sent it for molecular analysis. The assay we use is Thyroseq. Can you guess what the Thyroseq results showed? What is the mutation associated with multinodular goiter? Anyway, the patient had a thyroid lobectomy, and here is her lobectomy. You can see this Hashimoto's thyroiditis with Hürthle cells. Here is the nodule that was FNA'd. It showed a follicular adenoma, but there was an incidental papillary carcinoma arising within Hashimoto's thyroiditis. On high power, you can see the clearing of the nuclei and the orphan Annie appearance. It was BRAF negative, and I'll make this point, come to this point later. Usually papillary carcinomas are BRAF positive, but this was BRAF negative. IHC is not very useful in thyroid neoplasia, but just showing it what it showed in this particular patient. The Thyroseq results showed a DISO1 mutation with an allele frequency of 34%. And they said the probability of cancer was low, and it just indicates it's a neoplasm, maybe a follicular adenoma, or a minimally invasive follicular carcinoma or encapsulated follicular variant of papillary carcinoma. So what did our lobectomy show? You know, the proof of the pudding is in the histology, right? The molecular analysis can say what it is, but what did the actual specimen show? It showed exactly what next-gen sequencing said it would. It showed a follicular adenoma It showed an incidental follicular variant of a papillary microcarcinoma. So since then, in 2020, we have 2 more patients. A 39-year-old, the allele frequency for DICER1 was 64%. Resection showed a multinodular goiter. This is a 33-year-old, allele frequency was 22% for DICER1 mutation, benign adenomatous nodule on resection. So my question was, if this patient has a DICER1 mutation, does she have the DICER1 syndrome? She's only 26. Is this a germline DICER1 mutation? And when I went back again to Nikiforov and bugged him to tell me, does this patient have DICER1 syndrome? So he has recently written this very nice article on thyroid nodules and DICER1 mutations. And when they analyzed about 15,000 of them, they found DICER1 mutations in 1.4%. In our analysis of 300 plus cases, our rate is 1.2%. Now look at the age. Age is 37 years. Our patients were 26, 33, and 39. In 76%, they found a second mutation after sequencing the entire DICER1 gene. And Dr. Nikiforov has very kindly loaned me these slides, and I'll do the best to explain them. And so here is where the somatic mutation is. So when this thyroid nodule is aspirated and specimen sent, the mutation in that nodule is the somatic mutation, which occurs here. The germline mutation is here. Okay, so in DICER1 gene, the somatic and germline mutations are always different. However, this somatic mutation may be indicative of a germline mutation. The other thing to notice is that the DICER1 mutations are driver mutations. You don't see other mutations like BRAF and others. So the papillary carcinoma in the 26-year-old that on IHC was BRAF negative because it was not because of BRAF. It was because of DICER1. BRAF, yes, in most papillary carcinomas, you'll see BRAF, but there are papillary carcinomas that are due to RAS and also due to DICER1 and others. So this is a slide that also they have struggled with. If there is a hotspot mutation, what is the chance that it is germline? And when they studied, and of course, this is a small sample of 4, 25%, 1 out of 4, and look at the ages of the patients, 17, 29, young patients with DICER1. One of them had a germline mutation. So our patient had a history, family history of thyroid cancer, ovarian cancer. She was young. She had a goiter at age 15. Most likely she has a germline mutation for DICER1. What are the manifestations of thyroid with DICER1 syndrome? Multinodular goiter, follicular adenoma, papillary carcinoma, follicular variant, all 3 that were seen in our patient. In fact, if you see multinodular goiter and Sertoli Leydig cell tumor, that's suggestive of a DICER1 syndrome. What is DICER1 syndrome? It is an inherited disorder, precancerous syndrome in the pediatric age group. And individuals can form different tumors. I'm almost done. This is my last slide. So, but some people with the germline mutation may never develop tumors, and some of them, the risk is only moderately increased as compared to the general population. So I just want to end by saying that studying next-gen sequencing and doing next-gen sequencing has been very, very interesting to me as I combine it with thyroid cytopathology. I know that thyroid FNAs are a very common sample, and at AIMS, they've created their own gene panel to study what it is. There is also MedGenome offers such an assay here. Except for DICER1, most of the other genes are included in that panel. It costs about 40,000 rupees here for that such a test. So it's available in India. And I think it's exciting to combine next-gen sequencing with thyroid cytopathology. Thank you.